see my face?
No, they can't see you, but they can hear you. Vivian, Ella, and Emily, I don't know if the speaker is working, so can you just thumbs up react if you can hear?
Yeah,
we
can
can
hear.
see, but
Let's see, any thumbs up here? It's tricky here.
So I can't move too far.
You can't move too far. Okay, they can hear us. Wonderful. Just text someone who's here. Text Avery De Palma if you have questions. So now, if it's okay if I drive, just we share the PowerPoint there, and then now we do, and then you want to close your email?
Yeah.
Close your email. Now we share this. Share window. 3579.
Yeah, there's no way.
It's more complicated than it needs to be. And then do you want it in presenter mode? So there you go.
All right. And there's another talk after this?
At 2:30.
2:30. Okay.
There's an online talk right there.
Online? Okay.
Yeah.
All right. Hi, everyone. I'll start. Okay. So I was asked to give a talk on bone disease, saying including osteoporosis and rickets. I have to say each one could probably take 2 hours on its own. So I'd say it's a bit more of an approach to osteoporosis and rickets, using 2 cases that my colleagues had seen in the bone clinic. The way it works at CHIO is most of us as endocrinologists don't actually do bone clinic. We're fortunate we have a world-renowned expert here at CHIO. So Dr. Ward has her own bone health team, her own fellowship. So a lot of these slides, I have to thank my colleague and Rana, who actually were the ones providing the slides along with the cases. But I was trying to think, probably at your level as pediatric residents, it's more important to know how to do a good history and when to identify when you have to as well refer patients to specialized care. And congrats for those finishing off residency, and congrats for those who are almost done their first year of residency. Okay, so through cases, I guess focus on how do I do a good bone health consultation? What am I looking for when I'm asking these questions around, doing a good history on fractures? What am I looking at on physical exam? What are the investigations I want to order? And then when to refer to a bone health expert. So these are true cases. I know that there was a talk on Wednesday about factitious cases. That was an interesting round, but these are true cases. So this one is a 12-year-old who was referred in a bone health team by their family doctor for recurrent fractures. So, oh, sorry, and on the side, you guys have access to this, right? Because I dropped it in the folder of shared, yeah, okay. So you have access to this. But I ask that you don't necessarily share it amongst colleagues across Canada or wherever, because they are Leanne's and Rana's slides, if they can just really stay within the CHIO walls, let's say, okay. So going back to fractures, when you're asking around fractures, you want to know, well, you want to ask, was there the degree of trauma, which bones were broken, the location, was there displacement, how many fragments, what treatment were used, cast, surgery, was there repeat x-rays, see if there was healing or deformity. So for this individual, there were actually 4 fractures that this patient had. So starting off at age 5, had a left tibia fracture when another kid on a chair fell on him. 9 years old from the monkey bars, but it was a humerus fracture. 11 was a fracture, falling from 40 to 50 centimeters, and he tried to prevent the fall with his hands. And at 12 years old, it was a lower limb fracture, a right tibia fibula, when a classmate fell on him. So when you're looking at this, are you thinking, oh, is this concerning? Are there certain fractures that you're more worried about others, just by this history of fractures? Okay, when do you start saying it's a lot of fractures? Or is there some that are more concerning? And you don't have to have all the answers. I can keep going. It's just I want you to start thinking, okay, what is concerning, what's not. One thing you might ask is, well, do healthy children fracture? Of course, we see so many kids in the playgrounds, and well, many kids do fracture. So throughout childhood, you would see that about a third of kids will have a fracture, and the forearm is the most common site. I'm sure you're doing ortho rotations. You see how many fractures you'll have there. And the peak incidence of fractures is actually from age 10 to 14. And why is that? It's because you have this transient mismatch between growth and bone accrual during puberty. So when you're looking at these two graphs, what you're seeing in the dotted lines is you're actually gaining peak muscle mass, a lean body mass first, and then about half a year later, that's where you're getting your accrual of bone. So it's around that time, because that mismatch, that you're more at risk of having fractures. So one thing when you're looking at the list of fractures, you want to say, could some of these be considered low trauma fractures? That's kind of how you would differentiate if one is more concerning than the other. So how do you define low trauma fractures? Based on the International Society for Clinical Densitometry, it's a fracture that occurs outside of motor vehicle accidents or falling from 3 meters or less. But you also have other definitions. That a more conservative definition would be, well, if you're kind of falling from standing height or less at no more than walking speed. So, in that list of fractures, if you have a classmate that falls on you and you fracture, that's a bit unusual. One might consider, okay, if you're high up with monkey bars, I don't know how high you are, but we see. My 6-year-old is now on monkey bars, falls quite a bit. He hasn't fractured anything yet. Great. If you're having a humerus fracture, you think, well, maybe that's more concerning if you're falling off from monkey bars, as opposed to if it was your finger or your forearm. So I would say that from that list of fractures, there's probably 3 I would consider as being low trauma fractures. So concerning. Yeah. Okay, so now we've done that history of fractures. Other things you want to know on clinical history is, have there been concerns of any back pain or any pain in joints? And even in the extremities, sometimes you might hear from kids saying, they're quite tired after certain walks, where they need more breaks compared to their peers, or they need to be lifted up more often because they're not able to walk 10 minutes when they're going to the mall or other places with their family. You want to ask around nutrition, around calcium intake, vitamin D intake. I have to say, most people are vitamin D deficient, so you would have to take consistently 3 glasses of milk or more every single day for you to be sufficient in vitamin D. We ask about vision and hearing concerns because we have certain types of osteogenesis imperfecta where you can have hearing loss. In general, it's conductive hearing loss that might progress to sensory hearing loss after. Dental issues. So people that have primary osteoporosis, some conditions you might get this discoloration of teeth called dentinogenesis imperfecta. Sometimes you might get a referral from a dentist to say, this kid has unusual teeth and I'm worried about a certain bone conditions. I don't know if you've had anything like that where a dentist was referred to, no? but that might be a possibility. We ask about easy bruising because then you're worried about conditions like with laxicity, such as Ehlers-Danlos. And then you're doing a chronic disease screening as well, ensuring there's no GI musculoskeletal issues. And then asking timing of growth and puberty and where are they at on the growth chart? Do we have concomitant short stature or not? Mobility issues. And then what are things you worry about from medications that might impact bones? Steroids, yeah. So that's like the number one big one, whether we see it for conditions like Duchenne or leukemia. There are certain kids that are followed more closely for their bone health because of the impact of glucocorticoids. Family history. What are things you want to ask on family history when you're worried about someone having recurrent fractures? Yeah, recurrent fractures, short stature, vitamin D intake, especially if you're seeing. We've had a couple with presenting with, hypocalcemia and seizures secondary to vitamin D deficiency, and we realized, okay, on the maternal side there was also vitamin D deficiency. And same thing with, is there a history of bowing of the limbs or laxicity, easy bruising? You can ask those in the family as well. So when you're evaluating a child, you want to know in your head, you're evaluating, I'm looking for something primary, or is this a secondary osteoporosis, secondary to an acute or chronic illness? Okay, so for this patient, he did actually have a history of genu varum that resolved on its own. He has a history of leg length discrepancy. So one side is 3 centimeters taller. So because of that, he does have an antalgic gait when he's walking. He has pes planus, no back pain. And no back pain, no dental issues, seems to have a good calcium intake and does take vitamin D, which is great. No concerns with growth. So overall seems to be quite fine, other than unfortunately he's avoiding playing sports, fearing fracture because he's had so many. So things we look at on physical exam, you look closely at the skull, the sclera. So there's certain types of OI. You can have blue-grayish sclera. Now, if you have white sclera, it doesn't rule out OI as well. Just so sometimes you see these classic textbook pictures and you think this is exactly what I should be finding in my patient, and that's not always the case. Just so to be aware of that. Dentitions, you want to look at the teeth and make sure that there's no discoloration. So he did have leg length discrepancy. When you're looking at the spine, you want to be palpating the spine, like at each vertebrae, to see if there's any points of tenderness. That's really your way of knowing if there's localized pain. So there's the Baton score you can do for looking at hyperlaxicity, which on the next slide. Body disproportionality and doing your strength testing, upper and lower, to assess for muscle weakness. So, I mean, these are just pictures. Again, you might see these classic things and say, well, I might not actually see this, but if you do have someone with a lower limb deformity in the top, you know that they have a severe form of OI, along with the ones in the bottom. These are kids that, you would see in the bone health clinic or in clinics like a Shriners in Montreal. So dentinogenesis imperfecta is really an anomaly of the dentin. So you can see the chipping of the tooth. You can lose teeth from that, or have cavities because of that. And the sclera coloration, I mean, this is quite extreme. Sometimes it's very faint. It also depends on the lighting of your room, honestly. And so you could sometimes want a couple of people to have a look with you. So I don't know if you guys do this you're comfortable with this, or you're rating the fingers, your thumbs, your knees, elbows, and your spine to see if there's a positive score, and anything above 6 for children would be considered positive. And I assume you refer to genetics when you see a positive score with other clinical cues if you have the joint hypermobility. So for this individual, he was actually, I think he had the first, he had the first two measurements when seen in clinic. So he was growing fine, and his mid-parental height was at the 75th percentile. So no issues with growth for this individual. Okay, so I put it up there already, but you saw the slide. So, you know, you've done your history, your physical exam. Then you want to, I mean, we love our little blood work in endocrinology and bone clinic. So when you're doing your blood work, what you really want to do is you're trying to rule out rickets. Because any kind of bone abnormality, you first want to say, is there a mineralization defect? And rickets, usually you would have an issue with phosphate levels, where your phosphate levels would be low. So you can see for this individual, calcium, phosphate, alk-phos, PTH, they're all kind of normal. To ensure that there's no abnormalities on the CBC, I mean, sometimes, I don't know how many Leanne Ward has picked up, but she's picked up new onset leukemias in her clinic because of vertebral fractures, and then found that it was actually a malignancy. So yeah, so the CBC is quite important there. Thyroid function and IGF-1, we really just do for anyone with where growth concerns. We want to make sure there's not an endocrine component to that. Celiac screen we do as well, and a kidney function. So that's really, some of it is what you would do in the bone assessment clinic. Some of them are more kind of CHEO-specific, like the IGF-1. We don't order the 125 regularly. I'd say you would order that if initially on your first blood test, let's say if you had anomalies there with your PTH or your 25 vitamin D, then you'd order the 125. So we do an X-ray of the hand to look at the bone age, because we also, that helps us to interpret other things such as your bone density. But your hand X-ray is also a way for us to see if there's any changes suggestive of rickets, and that doesn't seem to be the case for him. And I think that his bone age was concordant with his chronological age, so it was at age 12. Okay, so in your head, when you're assessing for recurrent fractures, you know, the biochemistry as well and the history is helping you rule out rickets. But at the same time, in your head, you also have to rule out non-accidental injury. But rarely you can have both as well, but quite rare. But you should be suspecting maltreatment if there's delays in seeking medical attention, if you have unexplained bruising, multiple fractures in various stages of healing, if there was a metabolic survey done. You know, the history doesn't seem reliable, you're not able to get a good idea of how this person had a fracture. And then if there's no physical stigmata of congenital bone fragility condition as well. And it depends on what bones you're seeing fractures. So it's quite unusual to see fractures in your flat bones. So if you're seeing fractures in the sternum, the skull, scapula, you need to have significant trauma to have, like falling off a bike. But if there's no major trauma in the absence of rickets or osteomalacia, it could raise flags for possible non-accidental injury. Often in these cases, the genetic testing gets done to make sure you don't have, you know, collagen defect in some under those gray zones. So there's quite discussion that happens between child protection and the bone health team as well. Okay, so so this individual on, sorry, I didn't even say what, okay, so this individual on physical exam didn't have again pain when you're palpating the spine, did have the leg length discrepancy, normal teeth, and maybe had, in one note there was white sclera, and another note there was slightly grayish sclera. So anyway, maybe had slightly grayish sclera. So now you're doing the X-ray. Do you see it well? Oh, it's not really great on that view. I feel like it looks nicer on this one. Okay. So you do a spine X-ray, and you want a thoracolumbar spine X-ray. Could someone tell me what they're seeing, how you'd approach this? Yeah, how would you summarize what you're seeing in front of you? I feel like I want to walk over there, but then the people here won't hear me. So one rule of thumb is as you're going, lower down, the vertebrae should be getting bigger. and you don't only want to look at your size of your vertebrae, but you also want to look at your end plates and see, are they smooth or not? Are there areas of discontinuation? For example, this one here, right? You can see that there's a break here. So that to me would be interrupted. That would look like a sign of a fracture. But you can see here, by looking at the height of the vertebrae, for example, this one, you can see it looks quite crushed in the middle here, and this one, that there are multiple fractures that we're seeing. I usually like starting from the sacrum to orient myself where I am. So this would be, L5, 4, 3, 2, 1, and then I'm able to orient myself that, this one and this one are the same one. So then it's easy for me to find it from when I'm going lower down to up to orient myself where I am with my thoracic vertebrae. So he has multiple fractures, but he's not in pain and he wasn't symptomatic from them. Now, how would we classify that when we're looking at fractures? You have the modified Janant semi-quantitative classification for vertebral fractures. I have to say, often radiologists don't actually tell you what grade the fracture is in. It's more the bone clinics that are able to tell you exactly at what percentage do you have a fracture. So when you look at a vertebrae, in general, when you're looking at the height of the vertebrae, your anterior, your middle, or posterior should be more or less the same height, but we could accept up to a decrease to less than 20%. So if you have slightly, smaller on the top here, often your radiologist will say there's some wedging. I don't know if you've seen that with the radiologist impressions. They say mild wedging, mild anterior wedging. So that's not a fracture, because a fracture would really be if you're seeing that your height change from one segment to the other is greater than 20%. So for a wedge deformity, your anterior height, so this part here, is much shorter than your posterior part. So if it's quite severe, you can see it quite well on an X-ray. So I would say that most of us should have missed grade 3 fractures on an X-ray. I have to say grade 1 sometimes could be challenging, could be subtle. So it's classified based on the height decrease and also based on the type of deformity. So when it's a wedge, again, it was the anterior part that's more affected. A biconcave would be the middle part of the vertebrae. And then your crushed deformity would be the posterior part, okay? The other signs are, so as you saw the X-ray of the patient, is if you have signs of buckling or end plate interruptions, those are qualitative radiological signs of fractures that he had. Okay, so yeah, so this is numbered now, but yeah. So the next step is to do a bone density. Now, a bone density is two-dimensional way of looking at a structure that's three-dimensional. So you're looking at grams per centimeter squared. And when the beam, so patients are lying down, you have this beam taking your bone density. Now, having a measurement in itself is not diagnostic, okay? So you really want to know, how is this changing with time? So what is the trajectory? And what are the limitations of this? So could some of you mention to me some of the limitations of a bone density? So in what situations could you get a score? So actually, I didn't even explain the scoring. So in children, you're comparing your score of a bone density to someone of your same age, your same sex and ethnicity. So that's where you get a Z score. In adults, you get a T score because you're comparing the bone density to someone who's reached peak bone mass. You don't reach peak bone mass until you're mid-20s. So that's why for kids, we use that score. But what do you think might be some limitations? So I mentioned that. So think about, growth, puberty. Yeah, exactly. So someone who's short, you're going to have Z scores on the lower end because your surface area where the beam is looking at, you're going to be smaller. That's why you need more specific tests to look at the volume. So there's bone mineral apparent density that you can calculate. Someone who has delayed puberty. So let's say this patient's bone age or was 9 or 10, just like we look at predictions of adult height, we would actually, with our bone density as well, we would have to see, let's say the bone density was a 10, the bone age was a 10, I have to scroll and I have to ask the technician to actually interpret the bone density based on the bone age. That's why we also do the X-ray with the bone density. So if you're ordering a bone density, if you're in a community, do a bone age as well, and then you can ask them to interpret based on the bone age. So this individual's height was at the 75th percentile. So you have a bone density now that's kind of just under -2. Sure, from an absolute perspective, you can say it's on the lower end, but for this child who's actually quite tall, their bone density is much lower than you would expect. So, so starting off, as much as I said it's not diagnostic, I can say that, okay, as an initial BMD, it seems on the lower end for this individual. Okay. The other thing, so these are the limitations. The other thing is you can have people who have fractures even if they have a normal bone density, even if so that's, again, it's not diagnostic. Rarely you can have people sustain fractures with higher bone density as well. Okay, so the trajectory is useful if you're seeing a drop of more than 0.5 SDs. That could be considered clinically significant, but that's where we go into more details to, I don't know if you've ever clicked all the 10-page reports of your BMD. Has anyone looked at that? No. Okay. Start doing that. So you can see all the information. And the reason I say that is you can actually look for bone, the bone mineral content. So if I see a drop in Z score, I want to know if the bone mineral content is this patient still accruing bone, but maybe they're accruing bone at a slower rate. So I actually look at the content of bone at specific sites and I compare it to previous bone density. So I guess the message is, if you see a drop in Z score, that could just mean maybe the patient is, because if you look at your graph, right, in these ages you're supposed to be accruing bone. And if your squares, if I did another bone density and the square was, just a bit lower, that could just mean, if I can see that the patient's accruing bone, that could just mean they're not accruing bone at the rate they're supposed to be accruing in puberty. But if I see that the bone mineral content has gone down, that means they're losing bone, and that is concerning because you shouldn't be losing bone as you're trying to accrue that in your puberty years. Okay. So another fancier test, I don't order this. It's more the bone team is the, and you're going to hear more about PQCT or peripheral quantitative computed tomography, where at different levels of your tibia and fibula, you could actually get information on the muscle and the fat as well. And you can look at the bone to differentiate cortical bone from trabecular bone. So you get more of an idea of what's happening at the muscle bone unit in detail. So this individual did have a PQCT that showed lower trabecular bone as well. I showed the genetics, but so if you have this patient that has had recurrent low trauma fractures, what the next step would be you have enough to suggest this there might be a primary condition. So that's a situation where you would order genetic testing. And so the genetic testing did show that this individual had a mutation in the collagen gene. So how's a diagnosis of osteogenesis imperfecta? So in the chart, you would say this patient has osteoporosis. But what are all the ways to come to a diagnosis of osteoporosis? This individual had vertebral fracture. So that in itself, if you have an individual that has an unexplained vertebral fracture, that would fit the diagnosis of osteoporosis. Or if you have someone who's had recurrent, low trauma fractures, or a clinically significant fracture with a BMD Z score. Now, these definitions they change. So just keep in mind that whatever you're hearing now, maybe the ICSD might have a new definition in 5 years or 10 years. But so we're not using BMD as a way to diagnose. You can see in kids, you're looking at clinically if they're fracturing or not. In adults, it's different. In adults, you can diagnose based on your T-score, but not in kids. Yeah. And then you might have kids that, again, they're just unfortunate with the number of various little fractures they had. If there's no other reason, like let's say I had a kid that had various, finger, toe fractures from sports, I wouldn't do workup of that kid. I would say that kid probably is a healthy kid who's just, but if that kid had, was playing basketball and had a lower leg fracture, like of the femur, anything I would say lower limbs like that would be concerning as a fracture, and that would warrant the workup. So these are just pictures of what if you were to biopsy a bone, what a healthy bone looks like. So a healthy bone, you can see here on the sides, your cortical bone is nice and thick, and your trabecular bone in the middle. These are biopsies that Dr. Wards has conducted. So an example of someone with OI is you have your thin cortices, compared to your healthy one. You can see how thin this area is, along with a bit more gaps here, and then so having thin trabecular bone as well. And then there's examples of leukemia and myopathy as well. So what do you do in this instances where you're like, I'm not sure is this osteoporosis or not? I guess you got to add up, and it's almost like a puzzle, and you got to see, well, how many pieces do I have of concern? Whereas a jigsaw puzzle, I'd say, okay, this is concerning because there's various things that are adding up or not, right? So, for example, I was giving the example of a kid that had various little fractures, I'd say, well, maybe not as concerning, but if you're now you're starting to have more than 3, then I did a bone BMD. It seems on the low side, and there's other things that add up. Then your suspicion for bone fragility goes up. But then there's other things. For example, if you just had one vertebral fracture, that's already a red flag on its own. So that would warrant investigations, just having someone with vertebral fractures. Okay. I'm not going to go into the detail of this, But it's just for you to be aware that there are various genetic conditions where they present with primary osteoporosis based on your genetic mutations. So for example, patients with Ehlers-Danlos, they have the skin laxity, and then you have conditions with tall stature syndromes where they can also present with osteoporosis. All these graphs are actually from a review paper from Dr. Ward that I put in the first or there's in the second slide, like there's a reference there from Frontiers in 2004. So that's just an excellent review of osteoporosis. Okay, and then when you look at the genes involved in OI, where it's a collagenopathy, you can have defects. So your collagen 1 and 2 are primary defects in collagen structure or processing, but then you have other ones that will then affect your folding and cross-linking or the mineralization, or defects in your bone cells or your osteoblast development, which will then lead to secondary collagen insufficiency. So you have numerous genes now involved in osteogenesis imperfecta. This is obviously, I'd say, objectives of a fellow in bone health, not objectives for a pediatric resident. But this would be more, I'd say, objectives for a pediatric resident to name, well, what are some of the secondary causes of osteoporosis? So you've all seen kids with leukemias. You're always worried about, okay, that with, along with some of the hematological conditions like thalassemia. And then you have your class of medications. Interestingly, just a month ago, Dr. Ward had a referral for someone with severe back pain, vertebral fractures, and turned out that it was new onset Cushing's disease. The patient had it's still being worked up for a rare form of Cushing's called PPNAD. So I mean, these things we do see in clinic. So you always have to, in your head, when you're doing that history, obviously trying to rule out, is there a primary or secondary cause of osteoporosis? So OI is a genetic disorder of connective tissue caused by dysregulation and synthesis of processing type 1 collagen. These are individuals that are at risk of skeletal deformity, fractures, hyperlaxicity, scoliosis. You can also see chest wall deformities, macrocephaly, and a triangular facies. I went over this in a previous slide, but yeah, so you could get hearing loss in childhood, and that increases with age as well. So if you look at your collagen chains, actually, you have 3 chains, and then 2 of them are encoded by one gene, and then the other chain encoded by the other gene. And the majority, 85% of those with OI will have the autosomal dominant forms in collagen 1 and 2. I'd say this is usually the first genes that are tested, and then if those are negative, based on clinical suspicion, then other genes could be tested in the bone clinic. So again, you're trying to make your helix here, and then depending on what type of mutation you have in the gene, you're either not folding the helix properly, so that's leading to a qualitative defect, or if you have a non-functional allele, it can lead to a quantitative defect. All that leads to abnormal collagen, and that's what's leading to that increased bone fragility. Now, OI in the past used to be classified based on numerical type 1 to type 5, but now I think they're like at 20 or 40, lots of types. So they're slowly moving away from this, but basically the patient that I presented has type 1, has a mild form of OI. The mild forms of OI you'll pick up with someone who has normal growth and picked up later childhood, in the teenage years, and could have blue sclera, but could also have normal sclera. The ones that you see with the progressive skeletal deformity that are wheelchair bound, and you're very nervous with movements, with small movements could lead to fractures, tend to be your type 3s. So just from a picture perspective, so your type 1 could be like a healthy looking kid, just a healthy looking kid, and just, just that history of that recurrent fractures. And your type 3s are the ones that you see the deformity from a young age, and they could be wheelchair bound. So the type 3s are the ones that really need a multidisciplinary team with physio and ortho, and just various people involved. Some followed here, some followed at Shriners in Montreal. And unfortunately, the ones that are more type 2, you could also, is lethal depending on the amount of fractures. Have you guys seen any severe OIs in your NICU rotation? No? Oh, there hasn't been any? Sorry? Okay, you saw me. Okay.
There's one kid in
Nineveh. Yeah. Okay. Yeah, so the new system of classifying would use this dyadic system of what's the phenotype and what's the gene, what's the mutation of which gene has a mutation. So it will be, non-deforming OI and collagen 1 related, for example. So you might start seeing that more in the notes as opposed to the types. Okay, I'm just looking at time. So now you have this individual who's had fractures, has a genetic mutation. So you have to ask yourself, well, now we came to a diagnosis, what's the next steps? So the next step is, do you decide, do they need any bone, do they need bisphosphonate therapy or do they not? I have to say, it's still mainly bisphosphonates use it treatment, which is an anti-resorptive therapy. So the factors that influence you will be based on, are there risk factors that are persistent, are there or versus things that are transient. Why do we worry so much about the vertebrae is because if you look at adults that have had multiple fractures in the vertebrae and they haven't had reshaping, that leads to pain, that leads to lower quality of life. And there are some studies that even show that might restrict pulmonary function if you've had various vertebral fractures as well. So we haven't had any individuals from a young age followed with vertebral body shaping to see, well, how are they doing as adults from a quality of life perspective? But we'd assume if we're helping with that reshaping and reestablishing a normal bone density, that we hope that they won't have issues with back pain as they get older. So I'll give you an example of a transient. So give me an example of a transient risk factor where you might think, oh, maybe this one I don't need to do bisphosphonate. Did you think of what would be considered transient? Yeah, exactly. So let's say you have, and so Dr. Ward has done work on looking at leukemia patients and how they've been on steroids for, let's say, 3 months, 6 months, and what happened to the vertebrae. So the majority actually do show vertebral shaping for the younger kids that have the fractures. So if you have a 5-year-old, 6-year-old that has lower grade fractures, you know that there's this residual growth potential, you're not going to actually put them on bisphosphonate. So just monitor closely on a yearly basis to see how they're evolving and if there's growth of the vertebral body. Yeah, excellent. So that's a good one for transient risk factor. So for the persistent one, so we've seen many with Duchenne's. I know there's all these changes to their meds these days, but these were patients that for years were treating with bisphosphonates. And then for this individual, well, he still has room for growth. He was 12 when he presented. So there's time for his reshaping of those vertebral bodies. But the higher the collapse, the less chance as well of reshaping. So if your grade 3 fractures might not fully get to like a shape of a grade 1. Yeah. So how do bisphosphonates work? So if you look at bisphosphonate therapy and binding in the bone matrix, when you give bisphosphonates, it stays in your bones for years. So what it does is it really inhibits your osteoclasts from binding and from resorbing the bone. Okay, that's why it's called an anti-resorptive therapy. So you're preventing the osteoclasts from like picking up that bone. You have to look at that. Bone is a dynamic structure where I almost think about it like a Pac-Man game. Like there's constantly bones like being made and broken. So your osteoclasts are always working and trying to, fight off with the osteoblasts that are making bone. But there are newer therapies that are in a category of anabolic medication where you're trying to build bone. But for many years, we've really just worked on meds that are preventing further bone loss. But you'll probably hear about some of these newer meds in the coming years. Okay, so some of the effects, why we give bisphosphonates, you want to reduce the fracture risk, you want to help reshape those vertebral fractures. If there's back pain, bone pain, you want to relieve that, help with functional improvement as well. And you want to really just help with increasing that bone density. Okay, I'm just going to keep going. Other things is before we start on bisphosphonates, we want to ensure blood work shows normal vitamin D, phosphate, and calcium levels, because when you give bisphosphonates, there's a risk of hypocalcemia. So we do give calcium. I can't remember the protocol, but we do give calcium and vitamin D as well with that first infusion to ensure that the calcium levels stay normal. Okay, so ideal treatment, it really depends on, again, the persistence of factors or resolution. For some individuals, we do discontinue BMD, for example, the ones with cessation of glucocorticoid therapy. And others, if you have like a collagen defect, those are usually the kids that we continue ongoing. Okay, I want to get to the rickets. I realize the time. One thing you need to know about adverse effects is it can lead to flu-like symptoms when you're giving bisphosphonates. We have to prepare patients for that. And we talked about hypocalcemia and hypophosphatemia. Osteonecrosis of the jaw, they talk about that in adults, but we have not seen any cases in children so far for that. Okay. And the limitations is, well, it increases the width, but does not increase the periosteal circumference. And you're still at risk for fractures for those with OI. It's not to say that you're not going to have fractures at all, but we're looking at reducing the frequency of fractures. Okay, so I'm going to quickly, maybe 5 minutes, do a rickets case now. So this is a 6-year-old female that's referred for leg bone. So same questions you want to ask on history, but other things you want to know is more endurance of activity. So for this one individual, there were complaints of leg pain and fatigue. From a young age, she gets tired quickly, often asking to be carried after short walks. When running, she frequently stops, stating her legs feel tired and hurt. But she has been taking vitamin D, and what's unusual is she's developed a dental abscess despite maintaining good oral hygiene, and she denies back pain. So contrary to the first case, this one we see has short stature, okay? And you can see the height does not fall with the mid-parental height. On physical exam, you have similar things, but you want to know as well, if you're getting a referral for leg bone, you want to look closely on the shape of the bones. If you're more concerned about rickets, you're looking at certain areas like your wrists, your knees, to see if there's any flaring of the distal metaphyses. You want to know if there's any hypotonia as well, the genoverum and valgum, and if any leg length discrepancy. So these are kind of more textbook, I'd say more exaggerated ricketic rosary. Like I have yet to see a patient where you can see such a significant ricketed rosary. Sometimes could be small little bumps, could be quite mild. Craniotabes, you can see in infants first couple months of life where the skull is softer, but you shouldn't see it past a few months of life. So the clinical manifestations, if you see the pictures of A and B, you can see the widening here. Is that clear to you? Do you see it? Yeah. I have to say the infants that tend to be pudgy, it's really difficult. And you don't know if it's the bone or the fat. So, I mean, honestly, sometimes the x-ray is like the best way for me to know. But I have to say these are pretty significant. Like if you got to this point, it's because they probably have severe rickets. Yeah. The bowing, you can see it quite clearly here with the bowing of the femur, right? So the other thing is you look at the skin, there's rare conditions where you can get phosphate wasting like McCune-Albright syndrome, where in endocrinology we rarely see this condition, but you could see if someone has precocious puberty and has cafe au lait spots, but they can also develop fibrous dysplasia and hypophosphatemia. So you want to look at the skin for any cafe au lait macules. Now, when is bowing considered normal? So, you know, you could get the bowing in the infants as they're walking, but that should resolve by age 3 to 4 for the majority of kids. So in this case, you know, we ordered the same blood work as we did for the first case. Mind you, the 125 was added after, but you know, what was surprising for this patient was the degree of hypophosphatemia. Again, your first case, if you do have, as soon as you have mild phosphate, you have to go to root of rickets as opposed to, you know, going to root of osteoporosis. One thing I want to let you guys know is wherever you're going to go practice, always look at your reference ranges of phosphate closely, because your reference ranges in kids of phosphate tend to be higher than adults. So very common we get referrals for phosphate and we go, well, this is normal. Or this is, so you can look at your caliper reference ranges for that. In certain areas, North Bay or wherever you are, they might not report pediatric reference ranges. Yeah. So anyways, this patient's phosphate is quite low. So already and has also high alkaline phosphatase. So you're really going the route of rickets in your head. When you have a low phosphate, you then want to do a urine phosphate as well. So you're going to repeat your phosphate and do a urine one so that you can calculate, and endocrinologists and nephrologists love doing this calculation, but you're going to calculate your total reabsorption of phosphate. Now, someone who's hypophosphatemic, you would expect your TRP to be high because you're trying to reabsorb. You want to let your body keep this phosphate in the system. So it has to be greater than 95%. So I think hers was something like 90%, so it was lower. So we knew that she was losing phosphate in the urine. So rickets is a disorder of your growth plate, and you're failing to deposit sufficient bone mineral to achieve that necessary bone strength. So maybe I'll let you read this one after, just looking at the time. But on X-ray, what you could see is you can see the cupping, you can see the fraying, and the widening of your growth plate. Okay, and you see the fraying quite well on this as well. So these are quite, I'd say, you know, advanced signs of rickets when you're seeing this. And you know, when you have a consult with low phosphate or low vitamin D, I often ask X-rays, hands and knees, to really look at those locations. So phosphate is really important for bone. We always talk about calcium, but you need phosphate to really help with that mineralization. And the way phosphate works is it induces that differentiation, maturation, and apoptosis of those hypertrophic chondrocytes. So hypophosphatemia, remember this, rickets is a problem with phosphate, okay? So hypophosphatemia is a common denominator of all rickets. Even vitamin D deficiency that's nutritional, that will lead to low phosphate, and then you're going to get mineralization defects, and then you're going to get the rickets. So in what circumstances, what is an appropriate response to low phosphate? You would expect your urine phosphorus to be low. You're trying to hold on to that phosphate, right? Your FGF23 that's secreted by your osteocytes and that leads to phosphate excretion, we want that to be low. And your 125 would be high because you're trying to absorb then phosphate from your gut. Maybe this is more advanced. I just realized this is maybe a bit more advanced. But when you start off with a low phosphate, as in your diagnostic algorithm, then you measure your urine phosphate. If your urine phosphate excretion is low, well, then you have to ask yourself, well, this person is losing phosphate someplace else. Well, where's that going to be? It's going to be in your gut. So either look at the list of meds that might be affecting absorption. So certain milks, I know Nealcate was one of them. We were worried about phosphate. You can have malabsorption, but you have to look elsewhere if your serum phosphate is low. If your urine phosphate is high, so your TRP is low, and you see that you have high PTH, then that's a disorder of PTH, calcium vitamin D axis. So severe vitamin D deficiency that leads to high PTH, and that high PTH will then lead to phosphate excretion. But if your PTH is not elevated, then you order your 125. If it's inappropriately low or normal, then you're looking at some of the rare forms of hypophosphatemic rickets. So this patient, there's concerns about low phosphate. On physical exam, actually, she didn't have, in the notes, it didn't look like she had significant bowing, but they're concerned about her short stature, her TRP, her biochemistry. So they went with genetic testing for hypophosphatemic rickets, and there was a mutation in the FEX gene, and confirmed this diagnosis. So what happens with X-linked hypophosphatemia? It leads to inappropriately elevated FGF23, which is produced by your osteoblasts, osteocytes, and that inappropriate elevation of FGF23 leads to phosphate wasting. So she was basically gradually spilling this phosphate in her urine. What's the treatment of that? You give phosphate, but multiple times a day. But now in the last years, there's been a new medicine called burosumab, which is a monoclonal antibody and neutralizes FGF23. So that's the medicine they're on. So this is just to show you the graph of how burosumab works. But really what you want to do is you want to counteract that elevated FGF23. So the most common cause of rickets you'll all see is vitamin D deficiency, but I didn't want to give you a case of vitamin D deficiency. I want to give you a rare one. But we've seen so many vitamin D deficiencies, and sometimes they present with like hypocalcemia, seizures and stuff. But you want to just make sure if it's vitamin D deficiency that you're also supplementing patients, not just with vitamin D, but with calcium. Because if you just supplement with vitamin D, you might get a hungry bone syndrome where the bone's trying to get back all that calcium, and you want to avoid a hypocalcemia. So that's the end. I was able to, again, there's no way you can cover this in an hour. Maybe next time I'll say just split osteoporosis versus rickets. But again, at your level is really to understand the elements of what's important in history, some of the limitations of your investigation along with bone density, and when to refer. Okay. I would say any questions, but I realize there's no time for questions. But any quick questions? Okay. All right. Well, I'm available by email if ever any questions come up in the coming weeks, months, whatever. Any questions for anyone online?
No, thank you.
Okay, great. All right. Just close. I don't log them off, right? I will delete it, right? Okay.
You can log out of the Teams though, Dr. Khatchadourian, because it's your Teams account. So if you, oh, you guys,
Unless you want to log.
so then someone else can log in up there. Yeah, you should leave it to me.
Sorry?
Is this yours?
Yeah.
Oh,
Yeah.
okay. So you can log out then and we'll just log back.
Yeah, okay.
Hi, all.
Hi.
Is this like a mixed, like hybrid lecture?
Yes.
Ah, okay. Excellent. Did you guys, that sounded like a pretty in-depth lecture on rickets. Did you guys want a few minutes break before we start with a lighter topic?
It'll probably take the other group a sec to get themselves online.
Oh, are they all moving to online then?
I don't know if they're all moving to online, but they'll need to get some kind of screen set up for themselves. So that'll take them a sec to figure out.
Okay. Are they going to join as like a different, I guess they'll join as a, maybe as a group or something. Okay. How big is your class? And is this just R4s or is it going to be like it's the whole group?
The whole group and numbers vary. I'm not sure how many people are in person today, but
Okay.
anywhere between 10 and 30.
Okay.
And it's R2s to R4s.
Okay, no R1s.
No R1s, no.
Okay, that's good. This is probably a little bit far along for R1s, focus on your medical education stuff, but this is also important stuff for you guys as you're progressing through your residency to be thinking about. I'm just gonna get my slides up. I'll just leave it on the learning objectives slide.
Sure. Thank you.
So it looks like the big group is logged in. I'm not sure if they can hear you, but that pediatric residence should be them.
Perfect.
Hello, can you hear us?
Yeah.
Okay, there's a group of us. We just don't have a camera, so that's fine.
There we go. That should be good. Oh, wait. We want this. Good. Oh. Okay, you guys let me know if you're seeing like sort of a full screen sharing.
Yes.
Okay, perfect. Okay. Good. Okay. So maybe we can get started then. I'll introduce myself here in a second, but thanks everyone for coming today. This is going to be a much lighter topic than what you guys just did. It's more like sort of career and sort of like professional practice sort of focused. So the topic is about doing ambulatory care pediatrics, or basically office-based pediatrics. So I'm coming to you from Waterloo. My name is Dr. Jason McConnery. I'm from the pediatric section of the Ontario Medical Association. And this is a talk that was developed between our section and also with some support from the Ontario Medical Association for residency programs. Basically to give you an overview about sort of how to run a practice and some considerations around that. So during this talk, we will discuss how you set up a practice and some of the practicalities around like finding a practice, hiring employees, some of like the sort of terminology that you may need. I will share these slides with you afterwards. A lot of it is sort of a bit more reference based, so it may be useful for you if you're a fourth year. This will be like probably very relevant to you as you're heading toward your residency training. Oh, did you guys lose content?
Yes.
Okay, just a sec. I got a notification. Try that again. How's that, guys?
Yeah, we can see it now.
Perfect. And then for those of you in second and third year, this will maybe be helpful for you in terms of like thinking about if you haven't been thinking about having an office, like whether you should be thinking about it, as well as whether or not you should. You can also keep it as reference to refer back to in the future. We'll talk a little bit about management styles as well. Just putting out some ideas about what you might experience. This is relevant sort of no matter where you're working, but I could have put it in terms of scenarios within a potential like office. And then I'm a bit of an open book. So if you have any questions, you can always sort of ask me questions. But I will give you the opportunity like to sort of see some of the numbers of like a real world scenario, and that is my real world scenario. So a little bit about me. I'm from out east. I grew up in Nova Scotia. I did my undergrad at Dal and then went to med school at U of T. I did my pediatric training at Mac and then respirology fellowship at SickKids. And now I'm practicing as a pediatric respirologist in KW. That's a relatively recent change. For the last 3 years, I was also doing some general pediatrics and hospitalist call. So I've kind of done all of the things as a community pediatrician, and now more office-based stuff now. And I'm coming to you as the pediatric section secretary. That's how I kind of got into this role. Most importantly, I'm a dad of 4. And that is also the reason I may sound a little bit nasal today, because these little gremlins, even though it's the middle of June, are somehow still passing viruses around. So I apologize if I sound a little nasal. And it's good that we're virtual so that you guys can't get whatever I have. Just in terms of disclaimer and disclosures, the contents of this talk they're not meant to be as financial advice, but we talk about some numbers because I want to give you guys like the most accurate picture you can possibly get. And then just in terms of reference, I do reference some specific brands and companies that provide various services that can be helpful in terms of running a practice. Again, it's there as reference. I'm not endorsing any particular one. I've tried to do a relatively complete list where those sorts of things are offered. So our outline for today, we'll talk a little bit about options for office-based practice. We'll talk about how to pick out an office, some of the expenses and purchases you may need to have. Oh my gosh, we lost slides again, eh? Why it keeps them popping down. Just yell at me if it happens again. I'll just make sure I keep sharing because it's allowing me to share. You're seeing it again now?
Yes, we are.
Yeah. Well, thanks, Microsoft. And then we'll talk about staffing, and then finally we'll run some numbers. Stop me at any time if anything is particularly interesting to you or if you need clarification. And then before we sort of really go too deep on this outline, I also just wanted to take the opportunity to like ask you guys if you have any other specific objectives you wanted to go over. This is one of our talks from the pediatric section, but we also do some stuff on billing and whatnot too. So again, which is probably most relevant for sort of third and fourth year residents, which is I think why this was selected over that talk. But please let me know if there's anything else you wanted to cover. All right, perfect. If anything does like kind of catch your eye, please just raise your hand or unmute and ask. So let's talk a little bit about office-based practice. Do you guys have a general sense, like sort of how many people are thinking like purely hospital or purely tertiary versus like potentially setting up an office? Can you like, do you guys have a sense of who's headed for maybe having an office at some point? Maybe even amongst the fourth years might have a better idea as you're done in like 2 weeks or something like that. It sounds like there are some people. I saw one hand go up. So let's talk about some options you may have explored. As fourth years, you may have explored this. As again, as second and third years, let's be thinking about these options as you're moving forward, because you may want to also start exploring some of these options in your third year, or like be really exploring them in fourth year. And this might be a little bit late for for those of you who are like already figured out what you're going to be doing in July and or this fall. I'm not sure why this keeps on messing up. Let me are you guys still seeing like my full screen here?
Not anymore.
Not anymore. Okay. You would think it would work. Like this is Microsoft PowerPoint. You think it would interact well with Teams, but it does not appear to be. Pain in the butt. Okay, let me try this again. This is going to make it very challenging to show you guys PowerPoint slides. All right, so let's talk about some pro cons. There's two main structures for sort of having an office space. One would be under the model of subletting, and the other is like having your own office or sharing it with some colleagues. The subletting option is really, really a great way to get started. It gives you a lot more flexibility, but it does give you like sort of usually a physician landlord, though there can sometimes be institutional landlords that rent towards physicians. But oftentimes these are kind of like turnkey places that you kind of just show up. The office is already functioning. You can build your practice within that. But then generally you'll be paying a percent of overhead. It's various depending on where you are in terms of what costs are for those organizations. But definitely if you're going with like another group of physicians or something and you're subletting, you may get a better deal than like going with an institutional landlord. But the benefit here really is like you don't have to worry about the business side. You can just kind of go in, work, and they will take a percentage of your billings to cover your overhead. So you can really focus on the medicine. This is why it's a nice option early on, because your main learning has been figuring out how to use burosumab to treat to treat your rickets rather than necessarily how to run a business. And that's actually part of the reason why I'm here, is to give you some of that other context. Having your own office, it kind of locks you in terms of rigidity because you now have a space, you're going to have a lease, but you get to be your own boss and you can build your place to suit exactly as you need. And with the right sort of approach and organization, you may actually be able to get away with a lower overall cost, especially if you're using the office a lot or you structure your shared office in the right way. This does mean that you will have likely some component of office management as part of your job. So if you are a business focused person, this may be something you really enjoy as like a change of pace. But you are going to be wearing multiple hats now if you are sort of running your own office. In terms of subletting, you can sometimes negotiate a flat fee. This is where you would pay a certain amount to the landlord per day or per week. Try and negotiate that. If you can get a flat fee, that may be to your benefit, especially if you're very efficient, but you can always ask. What helps here is if you have a flat fee, as your efficiency goes up, then your percent of your earnings going towards overhead is going to go down. What's probably more common is a fee-for-service percentage. Tends to be the market standard. In most of Southern Ontario, it's generally around 30% of your billings. It can be more depending on if you're getting extra services, but oftentimes, yeah, you'd be expecting to be around 25. I am getting notifications pretty easily when it decides to stop sharing, so I'll just get it back up. You can get it down a little bit, depending on like how in demand you are, what community you're in. So you can certainly always negotiate that percentage as well. But generally 25 to 30% is probably market standard, and anywhere in that range based on like how expensive a real estate market it is. The advantage here is the cost scales to your work, so it can be a really great option when you're starting out because you may not be as efficient as you're figuring out how to work everything out. But as you start working more, and especially if you're primarily working in an office, like it can end up being quite a bit, to the point where it might be more than if you had your own office. You also want to make sure that you know if HST is being charged on that. There are certain ways around that for certain models, but most of the time, if you are paying to a landlord, they should be charging you HST for the service they're providing to you, which is including rent and managing an office for you. It can be an option to negotiate a cap as well. So if you are thinking you're going to be really moving quickly and you're not going to take a long time to build efficiency and get through high throughput in a fee-for-service situation, you could sort of project out like where you think you might be, like how much you might be earning after a certain amount of time, and try and negotiate a cap in before you sign any contracts. That way, if you sort of start getting to crazy numbers, you know, in terms of earnings, you're not going to be paying through the nose for overhead that you like paying too much for overhead, essentially. Now we'll talk about having your own office. So the solo offices are kind of going the way of the old school. It's just real estate is so costly these days that it can be really, really hard to justify having your own space just to yourself. Maybe in a circumstance where you're very busy, very efficient, and you're in your office every single day, then you can maybe make it work. But if you are any other mix of practice, then solo offices may be a harder economic sell for you. Again, this is just for reference, but like you'll want to be thinking as you're looking for spaces, like how much space do you need as a solo practitioner to be able to have enough room for your waiting area and, you know, a break room for you and your staff, and the number of exam rooms that you need. Generally in pediatrics, even though we're a lower paying specialty, unfortunately, we often have to budget for more space because you can't be working out of these like tiny little, oh my goodness. There's no rhyme or reason to why it stops doing this. You can't be working out of these tiny 80 square foot exam rooms that you'll often see in like walk-in clinics. You need bigger rooms so you have space for baby strollers and that sort of thing. So it is a bit inverse there with pediatrics. What's become increasingly common is having some form of shared office, because this is really just using the economy of scale to have a larger space for more people, and therefore you can save money by having sharing on shared office space, right? You only need so many washrooms, you only need so much break room, and so and so much hallway and et cetera, all of those sort of common area spaces can now be shared, and therefore that's going to reduce your cost because it really all comes down to square footage. The downside to having a shared office is, especially depending on the size, you may really be able to get the price down, but now you may have limitations in terms of the number of rooms that are available to you, how many days are available, who gets the biggest, nicest rooms, that sort of thing. So if you are doing a shared office, you want to know how it's structured. Some of you may be going to communities that already have shared offices created. You may be joining AFPs or non-AFPs, which are like sort of the funding plan programs. And in those circumstances, you want to know how they organize themselves so that you can know how you access those office spaces for following up your patients and doing new consults. One way that a lot of office sharing spaces work is through what are called cost sharing agreements. So I just put this out there so that you're aware, so it's not a foreign concept to you in the future. But these are basically formal legal agreements between a group of physicians that establishes that they're working together to save costs and that they're not operating as a business. And the benefit here is because you're not operating as a business, each member can contribute to the overhead without having to contribute HST. So that's going to save about 13%, right? So if the place costs you $10,000 to run the shared office, now it's not $11,300 because you're not having to collect that HST. So you can look into that and see how these shared groups are structured for you. Now, let's say you are in the privilege of getting to sort of build to suit your own office space, be it as a solo or as a new group. The first thing to always think about is your location. So as you choose the space, consider consider the actual factors within the community. So first, is it a city where you're going to be in demand, or are you going to be competing with pediatricians right down the street? Generally, there's enough work to go around, so you don't have to worry too much about that. But perhaps if you're thinking about doing more of a rural setting, you want to make sure that your catchment area is going to be accessible and manageable for you to be able to actually be full. You want to know, is your practice mix going to meet your goals? Other things, right? Quality of life. How will your commute be when you pick your location? And another thing, again, going back to some of those more underserviced areas, are there any incentives that can help you with moving to that area? There may be. A common place to ask is actually the town or small cities like Chamber of Commerce. They may have recruitment incentives, for example, or spaces set aside to encourage recruitment of doctors. And then next, consider the physical location. And this comes down to sort of what your practice is going to be like. So how's the parking, right? Most families are going to be driving, but it's helpful to have access to public transit if that's available in your city. Parking needs to be relatively generous, right? You need space for vans and sometimes wheelchairs for some of your complex care kids and strollers and so on and so forth. You want to know how close you are to lab and radiology services because you may be asking for those sorts of things. Sometimes you might be able to even find an office space within a medical building that has those things already in it. And then if you are going to be doing a mixed practice where you do some ambulatory care and hospital-based care, is it close to the hospital so you can jump back and forth if you need to? And then finally, are you thinking about potentially expanding in the future? Do you want to recruit more pediatricians to your group? Is there room within that building to expand? Questions before we move on to sort of the nitty-gritty of getting a space? Okay. Most physicians will lease. This is a much lower risk option for you. When you do a commercial lease, it's similar in a lot of ways to sort of renting like a condo. So you're not building any equity in that building. You are properly like a rentee and you have a landlord. Again, this is not like that fee for service approach. This is like there's somebody who owns this building and you're going to rent from them some space within that building or an entire building, for example. There are two key terms to know about. One is your basic rent, which is how much you're going to pay per square foot. That number usually comes out to, in most of Ontario, around $10 to $30 per square foot. Let me share, please. Thank you, Microsoft Teams. Around $10 to $30 per square foot. And, $10 might be in like a less desirable neighborhood or a smaller town or a very large space. You kind of pay more for smaller spaces per square foot and you pay less per square foot for larger spaces. And then you'll also have what's often called additional rent, or sometimes you may see it called CAM, which is like common areas and maintenance. And that's often in the range of $5 to $20 per square foot. And this is really like when you rent a condo, like these are like your maintenance fees. It's paying for the hallways, the public bathrooms, the parking, snow clearing. I'm sure you guys are familiar with that in Ottawa. And so depending on how much is incorporated and how old the building is and what the upkeep is, they estimate what the maintenance fees are going to be. And then they charge you those every month. And then there's usually a reconciliation at the end of the year. If they ended up having higher than usual maintenance fees because of a crazy snow year or lower than usual, then you'd get a rebate. And then the last thing to be aware about are inducements, and these are things that you can negotiate. So sometimes having a commercial realtor can be really helpful in these circumstances. And these are improvements to the unit that are paid for by the landlord to improve the space for your needs. And this is something that they are doing for you. If it's a major build, they may cover part of it. If it's minor issues, you may be able to get them to rectify that on their dime rather than on your dime. For example, like painting the unit versus like having to gut and rebuild. But this always sat kind of weird with me, but like if you're thinking about building out a space, your landlord is not going to build the space out entirely. They're going to expect you to put some investment into that, which is unfortunate because you're signing a lease for 5 or 10 years, but you're putting all of this money in up front to build a space for yourself, which you may not even be in 5 or 10 years. So again, thinking about where you're going to be, you are signing a 5 or 10-year lease. Are you going to be there for 25 or 30 years, an entire career? Then maybe those upfront investments might make sense. But it does always kind of feel weird to be putting a lot of money into improving a location that you're not guaranteed to stay in. Buying is always going to be another option. And this is if you're very like investment and business oriented, you may be able to find a property, be it a house with flexible zoning, or even maybe you get together with a large group to buy a medical building, or maybe even go into business with like a pharmacy, for example, and then you buy a medical building for the pharmacy and your clinic. This is going to be an investment, right? You're not paying rent anymore. You're actually getting a commercial mortgage, and you're going to be paying down that mortgage with your rent proceeds from the people who are renting from you, and also like the undergoing of your business. And so the benefit here is after a 25 or 30-year career, you probably own that medical building. And so you actually have that held within your medical professional corporation, this asset that you can then either continue to operate for financial benefit or potentially sell to help fund your retirement. But obviously higher risk, higher reward, and a lot more thinking to do with regards to that. This is more for reference again, but if you are having to build out your office entirely, if you're going from like a complete empty shell, so a full build out in Ontario at this time, this may be a little bit higher now because of the war in the Middle East and its impact on inflation, but around $150 to $200 per square foot. So it can be really expensive, like $200,000 to build out 1,000 square foot unit. So really the best choice if you want to save on upfront costs is to find the place that's already built out as an existing medical office, and maybe it just needs a coat of paint and some nice pictures on the wall. That's going to be a much less of a cost to you upfront. We'll move on to expenses now. Again, stop me if you have any questions. So setting up your office, it's not just having a room, it's also having the stuff in the room to be able to produce high quality healthcare. Having done all of this recently, these numbers are a bit variable, but probably if you're going a bit lean, you could probably even get under $5,000 per room. But I mean, there's a lot of stuff that you need to get, right? So a relatively basic exam table that actually looks like a doctor's exam table is about $2,500 new. You can look for used ones. They also do have what are called treatment tables, which are a little bit cheaper. But if you want it to look like a doctor's office, then yeah, you're looking at least $2,500 per exam table. And then depending on how you organize it, you may have a computer in that room, or you can go lean and use your laptop. That's how we do it in our office is everyone brings their own laptop and we just have monitors with HDMI and dongle attached so that we can kind of have a 2-screen setup. You may need phone, you're going to need some waiting chairs. You're going to need some printers, maybe not in every exam room. You could potentially centralize your printer if you want to go lean. And then thinking about exam equipment. So vital signs machines, these can be highly variable, but also tend to be very expensive. The ones you guys are used to in the hospital, like those like nice Welch Allen vital signs machines, those things are like $5,000. And again, this is another situation where it can be a bit tricky because pediatric stuff tends to be a bit more expensive because you need stuff that's like ideally you use stuff that's validated for pediatrics, and a lot of those products that are validated are a little bit more expensive. So for example, I was able to get I kind of broke it apart and I got a good oximeter for about $1,100 or $1,200, and then I got a good blood pressure machine for about 1,000. Versus like getting one of those all built in, everything together is like 5,000. So again, you can shop around if you're looking. Otoscope, ophthalmoscope sets are about $1,000 per set. They can be a little bit more expensive if you get one of the ones that are sort of like dockable for recharging. But the cheaper ones that just plug into the wall to recharge are about 1,000. And if you're doing anything crazy, like with like those crazy like ophthalmoscopes, because direct ophthalmoscopy is challenging, those are even more expensive. You need a scale for weighing and a baby scale. Those can be expensive. And then you can either put desks in each office. Many offices have what's called millwork, which is like kind of like built-in desks and built-in like sort of like surfaces. So it gives it a more professional look. And again, that can be quite expensive, and that's one of the major parts actually of like the cost for that full build out. But you can also just throw a desk into a room. That's also feasible. And then your common areas, you're going to need all kinds of different stuff. General idea, you're probably going to need about 4 waiting room chairs per clinician practicing at any one time. You may want a play area for kids. Your secretary and or secretaries are going to need a desk and a computer and a phone and so on and so forth. So all this stuff tends to add up. And then you'll have your ongoing consumables, all those disposables, tongue depressors, cotton swabs, otoscope tips, temp probe sheaths, exam exam table paper. All of these different things will sort of be there. Some of the things are going to be things that are going to be helpful to you in terms of billing. Like, for example, if you're doing vaccines, well, yeah, needles and syringes, you need those to be able to do vaccines, and then those vaccines you can bill for. So there's kind of like some stuff that's just disposable that you need in the run of an assessment, and the other things actually like generate income. For example, one of my disposables is mouthpieces for a spirometer. I mean, they cost me $4 for a mouthpiece, but I get to make money because I have that, and I make more than $4 on every test. So it all could become sort of that economic argument. And then you'll have all your basic office stuff that is just kind of standard disposables and consumables. Don't forget the toilet paper. Costco, you can buy stuff there too. And then there's some ongoing bills that you will have. You need commercial insurance. This is over and above your malpractice insurance, which you'll have from the CMPA. You can get quotes through a commercial insurance broker. But basically, you can think of this as kind of like slip and fall insurance. People can injure themselves on your property, and your malpractice insurance does not cover that. And so this covers sort of all of that other stuff. You'll need internet, phone. VoIP is a cool one that can be a good option because it allows you to be a little bit more live, and you can often get them bundled with your internet. VoIP is voice over internet protocol. So instead of having like a formal phone line, you get it through the internet. If you have like a really old electronic medical record, you may need to get your own fax line, but most of the time these electronic health records have their own faxes built in. It's like an e-fax system. And then depending on where you are and what kind of building you have, you may also need security. And by security, I mean like locks and monitoring and so on and so forth. Because as we just talked about, you have a lot of very expensive equipment in your office that would be very fun for a thief to steal. Okay. And then this is a huge, huge consideration. So electronic medical records or electronic health records. Ontario MD, which is part of the Ontario Medical Association, puts together a list of approved health records within Ontario. These are some of the options listed in alphabetical order. There's more, but these I've kind of like listed the most commonly used ones. Some of you may have seen these in action. Common ones would be for a lot of specialists are Acuro, and some specialists also use OsteoPro and TELUS. I've seen fewer people using these other ones, but I listed them for completeness. And the cost can be quite high. The less full service you are, it tends to be cheaper, and the more full service they are, tends to be more expensive. Like Acuro and TELUS can often be around $400 or $500, even $600 a month, depending on how many like sort of plugins and add-ons you have into them. But you do get what you pay for, and this is really what is sort of like the underpinning of your entire practice. It's how you make sure stuff doesn't fall through the cracks, how you document, how you prescribe. So it's really important to like try out different ones as you're going through training, see what you like, see what you don't like, ask your supervisors what they like and what they don't like about them, and then make sure you do your due diligence before you sign on with one of these health record providers. And then one really cool thing, you may be seeing some of this stuff, but there's lots of efficiency tech that's come out recently that can really help. In Ontario, Ocean is a huge system for community-based care, and there's often integration with hospitals as well. But this is an integration, it works with a lot of our electronic health records in the province. And depending on the level of service you're requesting of Ocean, it's often around $30 to $60 per user, and you can get significant benefits from it. I think when I was using it with my last office, it was around $30 per user, and it gave us patient engagement and reminders and e-forms. And with like, it was super, super helpful because it offloads your secretary from like calling families to remind them, because they're now getting texts and emails and they can click confirm, and it all just integrates nicely. And one of the other things that I had done with this with e-forms was I'd created an intake form which families would be asked to do. And when they do those e-forms, I actually, like, if you're a techie, you can kind of do this, but like it put out an output that was basically a consult note. So then I could just fill in my HPI as I was talking to the family, but like sort of most of my note is already generated. So you only have to do sort of an assessment and plan and update your physical exam, for example. AI is all the rage right now. There are a bunch of task agents that are out there that also can help with HR costs. These are a couple of companies. They usually are around $100 a month, but what they tend to do is they have like programs that can do reminders for your patients or automated task follow-up, and they also have inbox management. So instead of your secretary having to like look at a fax, figure out what patient it is, who it's for, it kind of just, the AI just reads it and forwards it to you so that your secretary doesn't have to do as much work. And one of the things we will talk about basically on the next slide is staffing in HR is one of your biggest costs. So anywhere you can reduce the demand on your secretary and therefore reduce the number of secretaries you need, pays itself back enormously. And then AI scribes are just great for your quality of life. If you can figure out how to use them and integrate it into your workflow, it can often save you a lot of time in terms of efficiency. And in terms of documentation and whatnot. Some of them also are doing really cool things. Like I think Scribeberry, like they have like automated like form completion for like disability tax credits and stuff too. So there's just all kinds of really neat ways that you can use these scribes and AI programs to make your life easier. Have any of you guys used scribes before in an office? AI scribes, I should say.
Our hospital is just starting to do it for some of the offices, like for some of the outpatient stuff.
Nice. Do you know what they're using?
I think it's Dax Copilot that's integrated into Epic.
Oh, that's right. Yeah, I think I've heard of that one. Yeah, nice. Well, there's all kinds of ones out there, so you can decide which one you want to use. But I know one of the community pediatricians that I've interacted with who works in Ottawa. He recently integrated, I think, AutoScribe, and he's been practicing in the community for many years, and he had said that it saves him about an hour of documentation per day. Basically just like leaving an hour earlier than he usually would have. So that's huge for quality of life, obviously, if you're getting a good result from it. Cool. So this is going to be a bit of a meaty topic. Some of the slides are a bit dense in terms of text, but again, they're there for your reference. Does anyone have any questions about location, office-based stuff, before we start talking about HR? Okay. All right. So as I mentioned, this is probably like honestly like the most stressful part of running a practice is like, someone's now actually relying on you for their income, beyond just yourself. So you have to do this right, and there are a lot of laws around having employees. So we'll kind of walk through that. In terms of potential staff, the most important person in your office is your medical office administrator or your secretary. They keep you running efficiently and they keep your patients happy. Um, they can help you improve your efficiency, like in terms of making sure that you're not having no-shows, for example. It's a huge cost. It sucks when you're sitting there for a 20 or a 30-minute follow-up and somebody doesn't show up. That has a huge impact on your income. And so definitely you want to make sure that you have a good secretary. Some of you may be doing bigger office plans, maybe primary care pediatrics, or just maybe like planning on having very high throughput. Honestly, if you are a very efficient and you're running in a fee-for-service situation, having extra staff, which allows you to bill more, is generally a no-brainer, because the amount that you can bill per hour versus the amount that you have to pay an extra secretary or pay an RN, if you can make a business case for like, this allows me to bill an extra $100 an hour, okay, well, my MOA costs me $25 an hour. So that is now an extra $75 an hour in my pocket. It becomes a no-brainer. So nurses, most community offices won't bother hiring RNs. They're more highly trained and aren't particularly necessary in a community office, but RPNs usually come at a lower cost and can be trained to do basically most of the things that an RN would do in your office. So you can consider those sorts of things. And then other staff, there's many different that you might need, like IT or janitorial. If you're really good with IT, maybe you can do it. That can be very stressful. There are also companies that provide off-site IT that you kind of have a subscription model with. Janitorial, you can find someone locally who does cleaning routinely, or maybe your building just includes janitorial in your rent. But those are some things about some people that you might want to hire. In terms of employment standards, you as a physician are still governed by the Ontario Employment Standards Act, or the ESA. And when you have a contract with your employee, it must be legally valid to be governed by the ESA. So you can put whatever you want in a contract, and that your employee can sign it. But if there are things that deviate from the ESA, then that contract can be, if there's ever like an employment dispute, for example, can be rendered sort of null. And then you can be at like risk of major litigation. So the key here is make sure, like, once you kind of put together a contract, either run it by your lawyer if you have like a corporate lawyer or something like that. And if you don't have a corporate lawyer, one of the services provided by OMA is the OMA Legal, and they will review employment contracts for you. So that is absolutely an option as an OMA member. So do that. That's really important. So some key features in terms of employment standards, number of hours that you can have someone work per day is the max daily is 8, unless there is a written agreement allowing longer. The way that works is you have to sort of say, the max I'm allowed to hire you per day is 8 hours, unless you agree to it. These are the hours that I'm allowed to hire you for. Do you agree to work more? And then that has to be like written into the contract, and then you have it. The max weekly is 48 hours. For every 5 hours worked, you need to give a 30-minute meal break that is unpaid. So for example, if you do an 8-hour shift, like 8 to 4 for your secretary, you're paying them for 7.5 hours and they get a 30-minute lunch, for example. And then overtime is generally paid for over 44 hours per week, and that would be typically time and a half. Again, there are ways, like, again, just make sure OMA Legal or your lawyer takes a look at it, but you can go above and beyond these max weeklies. But, if you're working in an ambulatory care setting, like, you probably don't need your secretary on for more than 8 hours a day. And if you do, like, it might make sense to just have a second secretary who runs over a swing shift or something like that. Termination is probably the most legally fraught situation as for the Employment Standards Act. There are two main ways of terminating, and one is with cause, and the other one is without cause. Without cause, it's limited to if they're sort of under that probationary period in the first 3 months, versus without cause over 3 months, then it becomes a bit more dicey in terms of like requirements. But basically, so with cause, this, you have to basically build a case for a with cause termination. With cause termination is defined as like the employee is willfully providing misconduct or disobedient or willfully neglectful, and it can't be trivial, and it can't be condoned. So you can't just sit there as like a passive participant and sort of say like, this has been building up, I've been stewing on it, and now I'm going to fire you with cause. It's like, no, like the first time you see the problem, you have to like address it and document that you've addressed it. And then if it continues, then you can build that case for termination with cause. When you are terminating with cause, you do not require to give them notice, and you do not require to give them any degree of termination pay. When you're firing without cause, it's a bit more of like one of those situations where it's a little bit less legally fraught, because you're not generally like, it's not like there's like issues that the employee is having. It's more like, we don't need you anymore, like for whatever reason. Or maybe it's even just like, it's just not a good fit. So it's just a little bit less tense and you're a little less likely to be litigated. It's just like we need to part ways type of thing. So if it's in that first 3 months, this is probationary. You don't have to give them any notice that it's just not working, and you can just terminate them, and there's no termination pay requirement. If it's been more than 3 months, the rule is that you have to give them notice. And this is to find another job, essentially. So you have to give them 1 week per year of service, including the first year after that first 3 months. So if it's month 9, you got through that probationary period, but now you want to terminate that contract, you have to give them 1 week notice that you are going to terminate them. And then it just keeps going up and up and up. If you need them gone, or like more likely, like let's say like the office is just shutting down. You've decided to move to Australia because of the weather, and you're shutting down your office and you're moving to Australia. You would have to give them pay in lieu of that lack of service. That lack of notice. And so if they've been with you for 5 years, you have to pay them 5 weeks termination pay. The last thing to be aware of is severance pay. So severance pay you may have heard of before, and severance pay is kind of the idea that, yes, I've given you your notice, and if I'm terminating you without notice, and I'm giving you your termination pay. Severance pay is over and above that. That is, I just mentioned it because generally physicians' offices will not require this. You need to have a global payroll of more than 50 people and more than $2.5 million. So unless you're like a big shot ophthalmologist, you're probably not going to be anywhere near this. But I just mentioned it because there is that distinction between severance pay and termination pay. Termination pay is required by the ESA. Severance pay is only required if you have like an enormous organization, which you will not typically be as a pediatrician practicing in an office. The full details of the Employment Standard Act are available online, but again, the main takeaway I would say is these are some details. that are highly important, but make sure your contract is reviewed by OMA Legal or your lawyer. Now that we are able to have a contract, we need to find our secretary. So make a list of what the job duties are, what the hours and the compensation are, and then create a job listing. You'll want to know what kind of credentials and experience you want. Do you want someone who is fresh, maybe coming out of like an MOA program at one of your local community colleges, or do you want someone who has a lot of experience? And then you'll start to recruit. So maybe check out the local colleges. I would like, my experience is the best option is word of mouth. There's like a social contract when someone's been referred to you for a job. And, you know, provided you can follow those pathways, I would say that's probably better than sort of posting on Indeed or the Canada Job Bank. I think most of my colleagues who run their offices really hate sifting through the piles and piles of applications, most of them not applicable when you post to these sorts of job banks. So definitely try and go with word of mouth. Consider training MOAs through your local college. Those can all be helpful approaches. It can be a little bit harder up front, but then once you've got them, you know, they're going to be helpful to you because you helped build them up and or they were referred to you. In terms of interviewing, and you can probably use this for like sort of anybody you might hire, use a multi-stage interview. You can start with maybe like a lower risk phone or Zoom interview first, and I call this the make sure they're not weird interview. It gives you an opportunity to like sort of like just talk to them and see where they come from and see how they see some of their perspectives and that sort of stuff. And then if they are not weird, bring them in for that second sort of like final level interview. Make sure they're still not weird in person. And then a couple of tricks that I've picked up over the years in terms of like how to assess the quality of a candidate beyond just like asking like this typical like sort of like, how would you deal with this or how would you deal with that? Difficult patient scenarios. There's the garbage trick. So this is when they come for their interview, you have them waiting in your waiting room, and you have some garbage with a garbage can nearby waiting in your waiting room, and you give them a few minutes and you see what they do with that garbage. And you know, it's not a make or break, but like you may be finding a very good candidate if there's someone who like notices garbage in the place that they're hoping to work, and they like pick it up and put it in the garbage can, right? That can be like a really good sign about attention to detail, quality, and sort of being helpful. Another trick is if you have other staff, like for example, another secretary and you're hiring a second, you could have them interact with that staff before they have their interview with you, and then you can get the feedback about how that interaction went. You want to make sure that they're on time because they'll need to be on time to open your office. And either the running late trick is where you are running late for the appointment, because as physicians, we know we're often running late because of patient obligations. So you can be running a few minutes late and see how they manage like not getting to start their appointment on time and how forgiving they are about that. It just gives you a lot of like sort of like human insights about how they would function in that situation where, you know, it often can be challenging and families can be very hard on your secretaries, and you may often be running behind. And so it kind of just gives you a lot of insight into like the intangibles that you're not going to get from just asking them about how they manage difficult patient scenarios. And then once you found your candidate, offer them a job, negotiate the rate if necessary, make sure that the contract has been vetted. You can do contracts. They don't have to necessarily be like a forever type of thing, which can sometimes make it a little bit easier to split if you just choose not to renew the contract. You can have a clear probationary period. Make sure that's in your contract. And again, if your contract is like ESA standard legal, then you'll also have stuff in there about termination. To give you an idea about costs, depending on level of experience, you could be looking at probably starting anywhere from $20 to $25 per hour. This is like the rate that you offer. It always is going to be a little bit more than that because as an employer, you also have to remit the employer portion of the Canadian Pension Plan, the CPP, and taxes, employment insurance taxes. I think my secretary right now is around $23 an hour, and it comes out on average to about 26, just with all of the additional fees. So just again, be aware that when you're doing your own budgeting and whatnot, the amount you offer is actually quite a bit less than the amount that you'll actually end up paying in the end as the employer. You can consider having a probationary pay with a quick raise if they're good, and this is like an incentive to do a good job in those probationary times. And then aside from just hourly rate, you can consider what kind of other benefits you can offer to them, and how you might structure bonuses, how much vacation you might offer, because there are standards by the Employment Standard Act about how much vacation is required. We'll talk about that on the next slide. But you can offer more than that to try and encourage employment with you. RPNs are in the range of $25 to $35 an hour. RNs are probably more like 40 to 50 or potentially even higher. And physician assistants can often be in that $50 to $60 per hour range. I mentioned PAs because they're really broadening their scope within Ontario, and they're becoming more and more available. And they can also, if you have plans for like a very busy office, having a PA, it's not that hard to argue. If you're going to get higher quality care for your patients and you can bill an extra $100 an hour, like, okay, yeah, I'll pay an extra $60 an hour to be able to provide higher quality care, and still make a little bit more money myself. So those are all different considerations. In terms of vacation and sick days, this is mandated by the ESA. If they've been working with you for less than 5 years, you have to give them at least 2 weeks of vacation, or the employee can opt to take the vacation as a 4% top up in lieu of paid vacation. So in this case, they would not get paid vacation if they took vacation, but they get more per hour. Over 5 years, you have to give them at least 3 weeks. And obviously, again, as I mentioned, you can give them more if you so desire. But you can structure it. Like if you say 4 weeks, that doesn't mean you necessarily have to give them an 8% pay top up. You can structure it however you want. But as you will probably be taking vacation, like one of the things I did with my secretary was I gave her 4 weeks vacation, but I said that 2 of those weeks have to be while 2 of the pediatricians in the office are also on vacation. So she gets 2 weeks, which was the mandated, where she can do it wherever she wants, and then she gets 2 weeks to take while we're away, which is good for all parties. And then sick days, there's no paid sick days that are required by law, but you do have to allow for 3 unpaid sick days. What this really means is that if you're having repeated unpaid sick days, you can start using that as a reason for termination with cause. But you could not start billing that case until they've had more than 3 unpaid sick days. And then benefits options, again, just listed here for your reference, but we are competing with other people for these secretaries, right? So hospitals, dental offices, these are hospitals just apparently have unlimited funds for hiring secretaries, and dental offices are obviously in the private space more so than we are. So they can often offer higher pay and benefits. So again, it can be really tricky as a physician trying to navigate this, and finding good people who want to stay with you, considering there are other good options out there. That you could offer, if you wanted to give benefits, there are health spending accounts you can sign up for yourself and your employees. You can also set up with like things like Canada Life or Manulife, and they have small business options, and that's like more of like a traditional benefits plan. And when it comes to pensions, basically the only option is to do something like, sorry, is there a question in the chat? Okay, no, okay. Basically the only option at this time is to do something like joining Hoop. This is a really recent new development that physicians who are medically professional or incorporated into an MPC can join Hoop. Hoop is the Healthcare of Ontario pension plan. This is what like every nurse is part of, every paramedic, anyone who basically works in a hospital can get in on Hoop, and now like medical professional corporations can, and then employees under your medical professional corporation can also join Hoop. So that if you are wanting to do Hoop for yourself, for your own retirement planning, which is not for everyone, but it might be the right choice for you, it could give you the opportunity to then offer that as an option to your employees for benefits as well. And then, oh my gosh, this is like literally nuts. No, that's not what you want to see. Good. Maybe that will work a little bit better. Nope, that doesn't work either. Sorry, guys, I've never had this happen to me before. Maybe I need to update my Microsoft Teams or something. So you get to work. It's really important as an employer to like pay attention to your employees, see how they're doing. It can be helpful to be structured. So creating a review checklist based on your job posting can be an easy way to do that. And kind of just sit down like maybe once a month for the first couple of months during that probationary period. Like, okay, are we meeting all of our milestones? Are we hitting everything that we need to do for these for your job? And so that way you can be giving feedback to really get the employee to be doing what you need them to do. And then perhaps having a more formal review after that first 3 months as they're heading out of that probationary period. This is going to be me. And then semi-annual reviews, probably a good idea going forward. Just again, so you can be having these structured situations where you can like seek feedback about how things are going and make sure that you're keeping your staff happy, because there's nothing that's more costly, as you've seen, right? The amount of work that goes into hiring and finding a good person. You do not want to be doing that routinely. You want to find someone and hopefully they just stick with you. Yeah. And then in terms of firing, we kind of already talked about this a little bit, but just make sure you write everything down if you're going to be firing them for cause. And that's typically going to be a 3 strike sort of policy, unless it's like major patient safety issues. And then the last thing is just sort of like the practicalities of payroll. So when you pay someone, you have to pay them their pay, plus you have to remit income taxes to the government, and also you have to remit their CPP and their EI. Part of their pay, their hourly pay, is going to be their income taxes, the employee portion of CPP and the employee portion of EI. So if you were going to pay them $1,500, they're not going to see $1,500. And you're going to end up paying more than $1,500 because you're also paying your portion of the CPP and EI. Probably the most realistic here. I tend to consider myself pretty techie, pretty thrifty, and do it yourself, but like this is complicated. You can theoretically do your own payroll, like you can write out your tax, like you can remit taxes through your bank. It costs like $2 per remission for filing. You can use online calculators to figure out how much needs to be remitted for EI and CPP. You can cut the checks yourself. And then there are T4s. You can download the PDF and fill it out yourself. Or you can just pay someone, one of these companies that I've listed here, to do all of that for you. You basically put in the hourly rate and the hours, and they do everything that you need in terms of making the payments and producing T4s and so on and so forth. Cool. We're going to get to real numbers in a minute, but those are like sort of like the foundations of some things that you will want to be thinking about if you want to have your own office. Again, I'll run the numbers with you guys after we talk about management, so that you can think about, is this for me or not? And then, but that's sort of the foundation. So we'll circle back to that in a little bit. Does anyone have any formal experience as an employer? Has anyone ever run a business before, like in your pre-med school life or pre-residency life? Anyone have any insights about that experience? Not really. Okay. So let's get into management. So this is a little bit more like concepts and stuff for you to use. You can come back to this as well in the future. But when we think about management, management is really kind of like, I'm using this term in terms of like managing your secretary, but like really these are leadership styles. And when you are a manager, you are a leader, but you can actually apply these in many different areas. So I hope that this is useful for you. And sometimes it's helpful to just think about these different management styles or leadership styles as you're interacting with groups, because you can kind of get a sense of like how you want to interact with that group, what's going to be the most successful. And thinking about how you use your leadership styles can lead to a lot more success and a much more frictionless experience as a leader in terms of making change. So in terms of autocratic management styles, there's sort of three subtypes. There's pure autocratic, persuasive, and paternalistic. Autocratic, you can kind of think of as, I'm the boss, so listen up. So this is really like the best situation for when you're in when there's a real emergency. Speed and precision matter more than discussion. This is the kind of leadership style or management style that might have been used during, for example, like the pandemic. But it's often very abrasive when it's not like an emergency situation. So it's like very dictator-like. So it doesn't necessarily create the best teams except for like helping find direction in crisis. Persuasive, we're still in that role of like sort of like telling the team where it needs to go, but you at least make some effort to explain why we're headed in that direction. So this is going to be more useful for like where your team or the people you are managing are relatively inexperienced, but you want to build that team. They need clear direction. You want to be on their side, and you want them on your side, and you know where to go. And then the paternalistic is you can think of as, for you to succeed, this is what we need to do. And so again, this is going to be in a situation where there's a strong sense of loyalty and respect. This is probably a little bit less, there's very, very rare situations where this might be helpful for you as like managing an office. Because again, as I've told you, it can be really hard to maintain these staff. So you want to sort of probably err towards more of a persuasive style with these less experienced people so that they can build loyalty. If they already have strong loyalty to you, that can be a bit of a different story. And in that case, you're kind of like sort of saying like, here's the rules. This is how we're going to get you where you need to be. And this is what I need you to do. And this is how you succeed in that role. Democratic management styles are probably the most common. You may be the most familiar with in terms of like your own comfort. We have democratic, consultative, and transformative. The reason I mention this as being most familiar is because we in medicine tend to work in situations or teams that are often not hugely hierarchical. There's of course always going to be some degree of hierarchy, and as the physician, you are often the leader of that hierarchy. But we are still a team providing care to patients. And so I think most physicians are probably most familiar with these sorts of styles because this is what's been used on them, and this is what you may have used as like sort of an early leader, perhaps as like a lead resident or something. So democratic, here's the goal. I need input on how to take us there. This really opens that dialogue where like your team is a bit more experienced, but you can kind of get buy-in by having that discussion and shaping that discussion towards the long-term goals. Consultative takes it a little bit more towards that autocratic direction, but it's like, here's the goal. So you're setting the goal as the leader. Let's decide how we get there. And so this is, again, an opportunity for your team or your staff to engage with you so you get more buy-in. And it can help with mentoring them. So this can be a great option, especially when there's like some degree of skill in your staff. Like for example, a secretary who's got a couple of years experience, you might invite that consultation to say like, hey, like, listen, we're having too many no-shows. Let's think together about how we can reduce the number of no-shows we're having. And then transformative, we've got a long way to go, but you can help us get there. This is like the Steve Jobs type of leadership style. We want people to take risks and grow and try new things together. Again, it's a bit more like moonshot type of style, but it's there. And then we have the laissez-faire management styles. This falls under laissez-faire and delegative. Laissez-faire is really kind of like when you have like a team that knows what they're doing, right? So like, let's say you happen to take over an office and there's like a secretary there who's been doing it for 20 years and they've been doing it for another pediatrician whose practice is very similar to you, right? They're already going to be independent thinkers who already know what they're doing. So they probably don't need much help or oversight. So you just say like, hey, listen, let me know if you need me. And then the delegative is talking about what you need and then let me know when you're done and I'll take a look. So this is kind of the idea that you trust your team. They have experience. They've got good instincts. You tell them what sort of the goal is, and then you let them get there on their own. You don't tell them how to do it. And then transactional styles. Here are the rules to win the game. Follow them to get your reward. So this can be helpful when you know where you need to go. And you're sort of very focused on results, and you kind of you create the game for that employee. That's not so much consultative as it is like, I trust you to get there, and if you do, this is going to be your reward. So which is going to be the best in an office? We really should be able to like take a moment and think about the situation, think about the team that you're managing, and decide which leadership style is going to be best for your goals in that circumstance. So let's move through some cases and we'll talk about what the best style might be for these cases. So here we have case one, a secretary. You're in your third year in your office. Unfortunately, your beloved secretary is left for a job at the hospital. You loved how she was running things, but you've now replaced a new MOA who's fresh out of college, who's now been working for you for 2 weeks. And despite your orientation, there have been a number of issues with things falling through the cracks. So which management style do you think makes the most sense here? Am I not sharing? Dang, it didn't notify me.
No, I think we lost content like for the past few slides.
Gosh, this is painful. Okay, so this is the case. Are you guys seeing it now? Yeah. Okay.
Yes, thank you.
Okay. So yeah, so you've got this new secretary who's quite fresh, and you're not happy with the outcome so far. Which management style makes the most sense here? Any thoughts? You can just unmute and say. Any takers? One of my preceptors when I was doing adolescent medicine said I was really good at letting an awkward silence sit.
Democratic?
Democratic? Oh my gosh, this is insane. Thank you for participating. So democratic might be a good idea, right? And you're going to be most familiar with this. What I would say in this circumstance, though, is remember you're 3 years into practice. So I actually think that an autocratic approach probably makes the most sense here. This is a brand new secretary with very little experience. You might use a more persuasive approach under that autocratic subheading, because we're not really in an emergency here, but a persuasive autocratic approach might be helpful for the strong personalities, or if they're more meek, then the paternalistic approach would be. But I think I would lean probably towards more of a persuasive approach for all personalities, but that doesn't always work the best, right? Some people just need to be told what they need to do. So in which case a paternalistic approach may be better. I don't think that they necessarily have quite enough experience necessarily to go for a democratic approach, but I haven't given you that much context, right? Maybe they had like a really, really good experience during their MOA training and they might have some ideas, but regardless, those programs are usually a year long and you've been practicing for 3. So you may have a better idea of what needs to happen. It stops sharing again. This is actually wild. So case 2 now, you're a new staff and you've taken over a well-functioning pediatrics practice from one of your senior colleagues. As part of the takeover, you've inherited their MOA. They've been working in the office for 10 years. It's now been 2 months and you're wanting to change the way that they're doing some of the things in the office, including incorporating some cool new tech options. And your secretary is very hesitant about some of these changes. Which management style makes sense here? So I think this is probably going to be more one of those democratic situations where you're going to be more successful, right? You're the boss, but you're the new boss. And the secretary is used to doing things in a certain way. And they're also very experienced, right? So maybe using that consultative approach will yield the greatest fruit. Talk about what the problems are and try and brainstorm together about some of the options. And then that way you can have a bit of a discussion about these tech options that you think might be helpful. And then help sort of shape towards the goal that you're looking for. And who knows, maybe they'll have another solution that's cheaper and as efficient to achieve your goals. Now let's talk about group office dynamics. Again, as I mentioned, most of the ambulatory care situations are going to be office-based and shared rather than solo. So you will probably be working in a group. So you've been practicing in this group with 4 other pediatricians for the last year. You all have a mixed office and hospitalist practice. You are the office manager lead. The volumes have really gone up in your office and you need another secretary to keep things running smoothly, but this is going to cost everybody quite a bit of money. So how you need to propose this change to your partners, which management style might make sense here. Then this is a highly functioning team, right? These are all people who know what they're doing and probably type A people. So a democratic approach is probably the best here. You can outline the problem that you're seeing as the office manager and use that as your position of leadership within this group of physicians, and then discuss sort of brainstorm. So this is again probably one of those more like democratic or consultative approaches to help soften the concept of everyone having to pay an extra $700 a month in overhead. And then group dynamic 2, so you're the managing lead of a group of 4 pediatricians, your mixed office hospitalist practice. None of your colleagues contribute to the day-to-day functioning of the office. You do everything in terms of management, and you're experiencing burnout from this task of managing, especially related to a recent MOA turnover, which has been extremely stressful as you're trying to find replacements. So you call a meeting to discuss a change to the organizational structure. What style makes the most sense here?
Would it be laissez-faire?
Remember that laissez-faire is going to be one of those situations where you kind of just say like, this is the goal, figure it out type of thing. And there isn't a ton of incentive for this group to be like, oh, we'll just take over like part of this then. Why don't we be the hiring team? That could happen theoretically, but you want to make sure that you kind of outline the goal a little bit more detail. Again, I may have kind of telegraphed this when I was talking about this at the start that we're most familiar with democratic options, but I think that democratic is probably going to get you the most efficient direction there and the most sure direction towards the goal there. Laissez-faire could work, especially if you have a very kind group, and pediatricians often are very kind. So if you just outline it and say like, hey, listen, I am burnt out from doing all of this, please help. And then they might be able to help. So Final reminder, we talked about a lot today. You can avoid a lot of this. This is a lot of stress and a lot of stuff that you guys probably haven't done before. You can avoid this just by subletting, outsource the office management to your landlord. You'll pay more, of course, but there are pros and cons depending on your structure of practice. But depending on how you value your time, what you like to do, and how you structure your practice, it may be worth it to go through all of this and learn this stuff. So let's talk about some financial modeling. I'm guessing the second and third years probably don't have much of a sense of how much pediatricians make in Ontario. The fourth years hopefully have been doing some shadow billing for the last year and can get a sense of how much sort of different services provide, but this may be a bit of a wake-up call for second and third year residents. So this is all of this financial modeling is going to be based on the most recent, oh, I lost my share screen again. Going to be based on the most recent schedule of benefits, which came out on April 1st. Okay, so some assumptions for our financial modeling. You need to know where you stand. What is your hourly rate and how many hours do you want to work? If you work slower or less efficiently, you'll have a lower hourly rate. And if you work more efficiently, you have a higher hourly rate. This is all under a fee-for-service situation. None of this really applies if you end up being on like full salary. I think most AFPs, including a lot of the tertiary care ones like CHEO, have some degree of you bill and you get some of your billings back. So at the end of the day, being efficient and working more quickly and billing efficiently is still going to yield you more earnings than if you are slower or billing less efficiently or working fewer hours. So again, some assumptions. These are approximations. The numbers are always going to be like 105.95 or something like that. So I've kind of just rounded it because I didn't want to put so many numbers onto this. It's already busy enough. So pediatric consult, it's about $190. There's always going to be an age premium on that up until patients over the age of 16. So I kind of just averaged it out. You can assume a consult is going to be around $220 on average, provided you are mostly seeing children under the age of 10. It might be a little less if you see a lot of teens. So thinking of just that service, if you do one consult in an hour, that's $220 an hour. If you do one consult in 40 minutes, it's $330 an hour. And 30 minutes is $440 an hour. So think about how quickly you do consults or how quickly you can do many consults. Some consults, of course, take longer and some take less. And then you can extrapolate what your hourly rate might be doing consults. Pediatrics in the community is a lot of developmental, behavioral, and mental health care. The K122 and K123 are specific pediatric mental health and behavioral and developmental counseling codes that you should use. They are time-based units. You have to you get paid 1 unit per 20 minutes. Or I should say the unit is 30 minutes. So it's the majority thereof, which is considered 20 minutes for the first unit and 16 minutes for every unit after that. So you would claim 1 unit after 20 minutes of service, and you would claim your second unit after you provided 46 minutes of service, and so on. K122 is when you're providing care directly to a teen or child. K123 is when you are doing it with a family member. So it's like individual behavioral developmental mental health care versus family developmental mental health care. So those pay about $116. Usually you're going to use K123s realistically. They pay more, and realistically the family is there for most, if not all, of the appointment. So that pays $116 per unit. Again, think about how quickly you're going to work through these. This is counseling, right? So you can't always necessarily control how long it's going to be, but just for the sake of math, we've kind of made some scenarios. If you do half-an-hour visits, that's $216 an hour. If you do if you structure things in a way that you're sort of doing like 45-ish minute appointments, knowing you like to talk, you could then claim 46-minute units probably times 2, which then works out to about $300 per hour over that 92 minutes. Make sure you document your times. This is a time-based thing. Or like if you are one of those people who can just cut off counseling after 20 minutes and sorry, I've got someone else I need to talk to. 3 of these in 20 minutes, it's going to yield you like $330 an hour. And you should know, we recognize at the pediatric section that this should get paid even more. This is very complex work, counseling teens who have mental health problems and developmental problems. So one of our priorities with the funds that are coming from our physician services agreement are to specifically increase these codes even more. And then follow-up codes. So A263 and A661 are the common follow-up codes in pediatrics. They make up about 4, you can use about 4 of these a year in combination. So, sort of a follow-up every 3 months or so. So that's usually enough. And there are other codes, and this is not a billing talk. This is for numbers progression sort of thing. These are the values. E078, again, this is not a billing talk, but this is a code used for certain chronic diseases. You'll want to learn what they are. If you use that diagnostic code with an E078 on top of one of these assessments, you get an extra 50%. So like an A263 becomes like $144 and so on and so forth. So again, if you are seeing a lot of patients who have chronic diseases that are eligible for E078, things like behavioral problems, asthma, diabetes, autism, these all qualify for E078s. There's a huge list of them. So if you see a lot of those, that's significantly going to increase your earnings. You could be like making like $400 an hour type of thing, doing like 20-minute follow-ups, which are not, it's not that crazy to be able to do 20-minute follow-ups. Now, the weirdness to the schedule of benefits is that there's actually like there's an additional amount that gets tacked on. It's called relativity. So these are the actual numbers that you would actually get in terms of hourly rate after you actually get paid, but this is not what you submit to the government. This is what you submit to the government, and then you get paid more like on these numbers when everything eventually kind of comes out in the wash. So we'll take those numbers. Let's create a pace. Relaxed pace would probably be, with those estimations, around $250 an hour. Steady pace, maybe $350 an hour, and hustling would be like $425 an hour. If you want to work for 8 hours per day, you can assume approximately 20% of your time is going to be needed for paperwork. That's a rough estimate. So for every 6 hours and 40 minutes of patient-facing time, you'll have probably about an hour of paperwork. So if we have 6 hours and 40 minutes of billable time, let's take the steady pace. That's $2,300 a day in office. Another way to think of the 8 hours per day and paperwork thing is if you worked 4 days per week of actual 8 hours, and then you took a 4th day, or the 5th day for paperwork, and just do paperwork all day on Friday or something like that, that would be the same, sort of the same idea. So let's talk about the subletting situation, right? So we're going to assume 30% of your billings are going to be your overhead. That's pretty market standard for a lot of like major cities in Ontario. So if you're doing 16 days a month like this, okay, that's $2,300 a day. It's going to be close to $37,000 a month in earnings. You'll pay $11,000 in overhead, so you take home about $26,000 a month. Yearly, taking home about $286,000, assuming you take 4 weeks of vacation. So really, that's like 11 months of doing that work. If you add in another day per week, you're going to do like Monday to Friday every day, sort of 8 hours. You'll do an extra, quite a bit, like an extra $6K per month you'll earn. So $354,000 is what you'll take home in this circumstance. Now, let's say you have a shared office. I kind of came up with like kind of a flat number. There's all kinds of different models for how you do a shared office, but like I kind of have done some polls about how much the office overhead can cost when you're working full time in an office, and around $6,000 or $7,000 is probably the high end. So I tried to go with high end with these estimations. Using the exact same number of days worked, you're going to take home $323,000, assuming 4 weeks of vacation. And if you work that extra day, $425,000. So that's that difference between having an office yourself and paying like sort of that lower flat fee as a result versus paying more because you're paying for office management. So another sort of example, this is going to be important because you can think about how you're going to be structuring your practice and decide what makes more sense for you. So if you're doing 100% of your time in office as a full-time pediatrician, doing that 30% billing, let's say you bill $40,000 a month, you're going to pay $12,000 a month in overhead. You'll take home $28K, $308,000 a year. So compare that to like where you have a flat fee. Let's say you're doing, oh my goodness, $5,000 a month in overhead. We could make it $7,000. We'll say you're going to bring home $35,000 a month. The annual take home is $380,000. So that difference between these two is $72K. So that's the amount that you're saving for managing your own office. If we make this $2K, obviously it's going to be about $24,000 less. So the difference will be closer to $50K. So those are the savings that you have if you have like sort of like more of a flat fee shared office sort of approach rather than renting from somebody who's managing an office. Now you'll have some responsibility for managing the office in that circumstance, and you kind of just ask yourself how much time it actually takes you to manage the office. If it takes you, and then you think about your hourly rate, then you can decide whether or not that management time is worth your time. Now, this whole argument sort of falls apart a little bit more when you are doing like sort of like more of like a mixed practice where you maybe have some time in office, but some time in other settings. Like for example, maybe you have a hospital clinic as well, or maybe you're doing some hospital-based service or call or something like that. So you're not spending every single day in your office as a result. The amount that you're going to be paying in overhead as a result in the fee for service situation, the percent fee for service is going to be lower. You're going to have income from other sources. So again, your annual take home from your office in this circumstance is around 176,000. Obviously, you'll have income from other places because this is not working very much in the office. This is maybe 50% of the time in the office or 45% of the time in the office. So that difference is going to start getting smaller. And so your return on investment goes down the less you use your office, essentially, is the take home there. So having a flat fee or own office, shared office space pays off the more time you spend in your office. If it's the only place you work, it's basically, like, as I've shown you, kind of a no-brainer. So learn the skills or find someone who has the skills that you can share with. But huge financial savings here. But again, that can introduce its own headaches as well, right? You might have conflict with your colleagues. Someone needs to be designated as main manager. So like all of these different things are going to be things you have to navigate. So the last situation, I'm going to share my experience because I've done both. So when I first started, I started with a 30% fee for service as it was the market standard at the time. It still is the market standard. I was commuting from Toronto to Waterloo, so I didn't like coming out very often. I would do 3 or 4 full day clinics per month. I was billing around $2,000 a day. And so I was paying probably close to $2,500 a month in overhead. That's manageable. I was working in a hospital as well at the time. So it was just like, that was part of my income, but also nice having an office. But then as I got deeper into my practice and as I got more efficient and running more clinics, I started making more per day. And as a result, I was paying quite a bit in overhead. So last year, which was my final full year of working in that office under that model, I paid over $60,000 in overhead. And I was kind of just looking at those numbers and sort of saying, this is nuts. So this year, I started a group office with my colleagues. It was already built out. We just put some paint and some new floors in and furnished the place. So it wasn't a huge outlay in terms of financial upfront. And right now it's 3 pediatricians, plus we also have a lactation consultant, and we have room. So right now we project around $127,000 in overhead per year. And this is all, the way we did it was we scaled it to billing. So we start at 30%, but it kind of gets pulled back when we have overage, which is sort of the model. So we actually get down to lower rates than that. So we're actually saving money by being in our own space, and we get the benefit of having our own secretary and our own space and pride in our location. So my projection for overhead has gone down from like, it was 60,000 last year. I'm working more, and yet my overhead has gone down to about $40,000. So I'm saving about $20,000 by being in this new office, as well as my colleagues who are also in the fee-for-service percentage office are also paying less now as well. $20,000 might not sound like a lot, but if you take that money and you leave it in your corporation and you invest it, compounded over 25 years, that could be an extra $1 million in your corporate account by the end of your career. So it definitely is, the point being that this is all very doable. In terms of looking forward, a lot of this probably feels very daunting, but the pediatric section and the OMA's medical network, they're doing some heavy advocacy on overhead costs because overhead is exceedingly expensive and increasingly expensive. I alluded to the hospital challenges and the dentist office challenges and so on and so forth. And we're basically creating, sort of free healthcare infrastructure for the government. So there's a number of different models that are being proposed right now to reduce the cost or at least increase the income when you have overhead or reduce the cost of overhead. So that's all sort of being explored right now. And I think there's just increasing recognition that acute hospitalist-based care is not the best for patients. And so having good access to ambulatory care can prevent acute problems. And so we're trying to figure out how to get the government to incentivize that kind of care, as they are currently not. So that's the end of the talk. I think we had been scheduled for 2 hours, but it's about an hour and a half. So we have time for questions, discussion. Again, I'm happy to share my slides. And I'm also, like I said, an open book. So if you have any sort of more candid questions, you can, of course, ask those as well. Yes, Nia?
Thanks for the presentation. This is more, I guess, not fully office management question, but what do most physicians do in terms of healthcare coverage for themselves?
So when you finish your training, provided you're staying in Ontario, Ontario has a program called the Ontario Physicians Insurance Plan, or OPIP. This is something that you can join free of medical health proof within the first 3 months of practice. So are you 4th year?
Yeah.
Yeah. So like, make sure you're opening all your emails from the OMA and jump on that when you get out into practice. Because if you have any pre-existing health conditions or if there's a strong family history of something and thankfully nothing has developed but you're worried about it, you can get on free of a medical. There are various tiers. There's OPIP, there's OPIP plus, there's OPIP plus dental, and then there's OPIP plus dental. And it's basically just different tiers. Each one will be a little bit more expensive than the last. Dental is quite expensive, to be frank. For my family of 6, we went with just OPIP. It covers like tons of paramedical, tons of therapy. It's got decent coverage for prescriptions. I think it's around 50%, but then up to a max. And then once you hit your max, like, so if, for example, like you got diagnosed with something where you needed like biologics or something like that, you might pay like a couple thousand in a year for that. And then you hit your max and then the rest of it would be paid for. So it's relatively good and not too unaffordable. And then the OPIP Plus adds a little bit of extra coverage. I think it's 90% coverage right from the start, and a bit more paramedical. And then the dental is just very expensive.
Thanks.
And then the one other piece with OPIP just to be aware of is while that's like a classic sort of health benefits package, they also do offer a health spending account. So if, for example, you have a partner who has a more traditional job and they have benefits, you can apply for OPIP yourself and get like traditional benefits. But there is the cheaper option to do a health spending account, and some physicians do that where they have like a partner who has good benefits. You get a health spending account, which gives you some more flexibility to spend those funds on things rather than having double coverage. And yeah, I used to be, so I was the new to practice rep. So I also developed a sort of transition to practice guide, which covers like all of this, Nia. So if you are wanting to get that guide, it's available free to residents through the pedsontario.ca. You just have to sign up as a member. So I'll just put it in the chat, but you can email our executive director. Her name's Angie. She can set you up with a membership, which is again free for residents and fellows, and you can get free access to that transition package. It covers like a lot, getting a billing number, insurance stuff, disability insurance, life insurance, some setting up a practice kind of stuff. There's a ton in there. Any other questions?
Would it be possible to get a copy of the slides? I think
Yeah.
you mentioned. Okay, perfect.
Yeah.
Thank you
Is
so
there
much. This was
is
really
there is there one person I can send this to, and then you guys can distribute?
There's Mahi tab, but if not, I can put my email in the chat and then I can share it with add it to the folder for the residents. Here, I put my email.
Perfect. Yeah, I'll send the slides to you.
Thank you.
Yeah, no problem. There's one other thing I was just thinking of. It's escaped my mind. It's probably the viral particles coursing through my blood. Okay, cool. Well, I'll give you guys your 24 minutes back or whatever it is. Or 20 minutes back. I hope you guys have a good rest of your week. And for those of you, oh, I remember what I was going to ask. If you just like in terms of feedback for myself, this is like the second time we've done this talk. Can you give a thumbs? Can you do thumbs up on this? No reactions. Can you do thumbs down? Can you do a thumbs up if you feel like this made you feel like you should consider ambulatory care or like office-based pediatrics more than you were before? Okay, awesome. I'm seeing lots of thumbs up. That's one of my, honestly, it was one of my goals because I feel like when I left practice, or sorry, left my residency, I was really scared about having an office. And I was like, why would I want an office? Like, it's like I can make so much more if I just work in a hospital. And then I realized, especially once I had kids, I was like, I don't love being on call in the hospital at night. And also like running the numbers, like I can actually do pretty good in my office, working like sort of 9 to 5 or not actually do 9 to 4. So like it's just like I want new grads to be aware of the option and they're like and have the tools to be able to do this because it can lead to a really great quality of life. Speaking from experience, it can lead to a really great quality of life once you kind of get over the mind block of like how complicated it can be to run a practice. It's like, oh, like I'm a couple months into running my practice like on my own, and it's like the first month or two was like, oh my gosh, like how do I run payroll? And now it's just like, That's fine. You figure out your processes and it's not super stressful. So that's good. So I'll also just put my email in the chat. If anyone has questions about community pediatrics and questions about the pediatric section of the Ontario Medical Association, we are always looking for resident representatives. It's a great way to understand the landscape of pediatrics in Ontario. You guys may know Natalie Giroux. She's a pediatrician in your region who does primarily developmental pediatrics. She's on our executive board. But I was a resident rep when I was a resident, and it was very, very educational and made me so much more prepared for practice and billing and everything. So if any of you are interested, feel free to reach out to ask more about what that job looks like as well, or anything else. I wish you all the best of luck. And for you second and third years, enjoy the final end of the race.
Thank
And
you
fourth
so
years,
much.
congratulations. Bye, guys.
Thank you. Bye.
Thanks.